we all agree that this is a very, very challenging clinical situation, stage 3 NSCLC. So almost everybody has a role to play from medical, surgical, and radiation oncologist. And so let's dwell into the case. So this is a case that is a hypothetical case, not managed by me, but I think it would serve well for us to actually go through for a discussion. A 52-year-old male, chief complaints of weight loss of more than 10 kg, cough, no comorbidities, and we'll assume that he's a non-smoker. The X-ray was showing, the X-ray was done and it showed lesion in left upper lobe and middle lobe of left lung, and a CT chest was done subsequently, and it showed a large lesion, enhancing lesion with necrotic component in the apico-posterior segment of left upper lobe. And there were few subcentimetric and enlarged mediastinal lymph nodes were seen, and this was the initial picture, and a PET scan was done on that. So if you see from previous presentation by Dr. David Vincent, and we can clearly see that the disease load is much higher, and this is probably more reflective of the cases that we see in our clinical practice. I think all of our panelists would agree with me. So we don't see that small T1 or T2 or difficult lesions. We get these big lesions with big nodes even in stage 3B. So a CT guided biopsy was done and poorly differentiated adenocarcinoma, TTF1 positive. So on the PET scan and on the biopsy, the final diagnosis that was arrived to at was adenocarcinoma of left lung, CT4 because it was more than 7 centimeters, and N3 because the contralateral nodes were already also involved. So let me first get the opinion of my radiation oncology colleagues. Dr. Harpreet, if we can go first, what is your intent, sir, for treatment of this case?
Since this would be, I think, stage 3B. So
3C, sir, rather.
Yeah, 3C, yeah, the contralateral opposite side, and then the supraclavicular. So what I would prefer to start with the chemo radiation. If the patient's performance status is good, so we would go for that chemo radiation as per the current protocol.
Okay, Dr. Sushma, are you okay with going ahead with CTRT upfront, or do you think the lesion volume seems a little high for going for CTRT upfront?
Yeah, true. The volume is too high, and in my practice, I started initially with concurrent chemo radiation in lung cancer patients, but I observed a lot of toxicity, and when I used taxanes concurrent, many of the patients landed up in ARDS. So therefore, taxanes concurrent is a no-no for me, and concurrent etoposide and cisplatin may be given in very fit patients, but this volume is too large, and in my practice, I usually give 4 cycles of NACT followed by radiotherapy.
Okay, so Dr. Mujammil, your thoughts on NACT? Do you think, do you concur with Dr. Sushma, or do you take Dr. Harpreet's path, and what is your take?
Yeah, first, the first thing is that what is the intent of treatment? I don't think so this patient will be cured. It is 3C, just short of one step, stage 4. Second, the disease bulk is so high that we cannot go for the CCRT upfront. Yes, there is good performance in this patient, but you have to see that there is 10 kg weight reduction as well. So there is a disease for long standing. So best would be the induction chemo, then followed by the sequential RT. That would be the good, or then CCRT. First of all, you have to decrease the bulk of the disease.
Okay. Dr. Harpreet, coming back to you, sir, what are the volume considerations that you, as radiation oncologists, plan while planning for CTRT? Anything specific to such bulky diseases, bulky 3B, 3C diseases?
What we generally do is during our simulation, only we just plan for the tumor movement. And if the tumor movement is high, we go in for gating. Otherwise, we just follow it with the ITV. We create the ITV with the inspiration and expiratory films. And if the size of the lung, if the size of the lesion is such that we can save a significant portion of the lung and the opposite side also. So that's how we plan, and this is an apico posterior segment, so we don't expect much of cardiac issues. Yes, esophagus is going to be a problem because of the nodes, and the maybe some swallowing difficulties might be there with the patient later on also. So we try and plan with the IMRT or an IGRT, basically an IGRT technique, which we do some image guidance during the treatment.
Fine, sir. Dr. Akhil, your thoughts about the discussion so far? What is your plan? And will you take the last question as well? Any other investigation you would do for this particular patient?
So what I try to get information from our radiation oncologist is the V20, whether it can be achieved or not.
Fantastic.
If V20 can be achieved, then definitely we'll try based on the performance status. If it is good, we'll try with upfront CTRT. But we have seen there is our publication from TMH Mumbai as well, where we had given 100 patients neoadjuvant chemotherapy. Not the standard negation, not the standard N2 node. Beyond N2, we had given pemetrexed cisplatin or pemetrexed carboplatin based NSCT in such patients because of these real world scenarios which we encounter in practice, and we found that it is actually useful. That is why we were able to give some actual data to our practice. So PEMCIS or PEM-carbo remains a very good choice in such patients for debulking the disease. And we can also understand the biology of the disease. If it is having a good response, then it merits definitely further treatments in form of CTRT. In terms of any other investigation, definitely I think brain, and I would also like to get EGFR in the patient from the baseline itself, so that I can understand the same.
So I lost you at the last point. So you said any other investigation, PDL1 and EGFR? Is that
PDL1, EGFR, and MRI brain?
MRI brain. Fantastic, fantastic. So so very agreed with all the points that you have made, Dr. Akhil. So discussion with radiation oncologist regarding the volumes that the healthy lung is going to get exposed to the V20, and this is actually a real world scenario where probably I would also tend to give NSCT. Thank you so much for making all the points. So ultimately it is a discussion, closed discussion. I think at least surgeons we would be leaving out in this particular case scenario, but at least the radiation oncologists and medical oncologists have to come together to plan for this particular patient. Otherwise, for all stage 3 NSCLC, it is MDT is the way to go, and this is actually what this particular data also shows: clear separation of curves in patients who have been treated by a close-knit or core group MDT versus without MDT. This is the point that Dr. Vincent was also making so eloquently. And this is the NSCLC, the stage 3 NSCLC ESMO guidelines. We'll skip to our case now in the interest of time. So this patient was given Pacli-carbo as NSCT for 3 cycles and was assessed after 3 cycles, and a partial response was achieved. Obviously, the treating doctor at that time also felt concerned with the disease bulk, so like majority of our panelists. And after this particular scenario of neoadjuvant chemotherapy, he was taken up for chemoradiation. And Dr. Mujammil, coming back to here, are you okay with the chemotherapy arm that was used as concurrent? Do you do Pacli-carbo for your early phases, or do you do histology-based selection?
It's all okay. It's okay. For endocarcinoma, you can go for the Pacli-carbo or PEM-carbo. As Dr. Akhil was also saying that, yes, PEM-carbo, it's less toxic than that of the Pacli-carbo. If it's tolerating very well, there's no problem. Pacli-carbo is good.
Fantastic. Dr. Sushma expressed some reservations about taxanes. Dr. Harpreet, your opinion, anything that you specifically would want to convey to your medical oncologist that I am not compatible with this particular combination of chemotherapy or something like that?
Not necessarily, but yeah, the doublet with the Pacli, it might cause more of esophagitis compared to the non-taxanes. But otherwise, I think it is, if the patient is tolerating, it's good enough.
So I would like to add a point here. Both the drugs, either Pacli-carbo or cis-etopo, both have their own toxicities. So cis-etopo will cause more of myelosuppression, while paclitaxel will cause somewhat increased pneumonitis. We are running a phase 3 investigator-initiated randomized trial. We try to put all the patients in the trial so we can have a randomized data to know which one is better, if any, or what were the toxicities at the end. And this is a large study in recruiting more than 300 patients. So it will take at least 5 years for us to get there.
It is fantastic that you have initiated the study. I think it is, I mean, it makes a lot of real world sense actually. So yeah, so Dr. Akhil, you mentioned regarding, we'll come to this later, concurrent versus sequential, but I will take the next question first. Suppose if you start pemetrexed carboplatin in this particular patient, how would we sequence the treatment? Let's say it's a CCRT setting.
In CTRT, we like to start both. Yeah. So most of the time we try to give concurrent chemoradiation, not the sequential. Sure. There's only one data for sequential. It is for elderly patients, and that has been published in last year in Journal of Geriatric Oncology, where we can give RT alone followed by chemotherapy. This is for patients of age more than 70 years, where we think CTRT will be too much and it can cause significant problems. So and there we can use in selected subgroup only radiation alone followed by 4 cycles of chemotherapy, but all other places CTRT.
So
I would like to
chemotherapy.
I would like to interfere.
Yeah, please.
Yeah, there are guidelines for resource constrained countries. I think it was published in Clinical Oncology way back, 10 years back. And they say that for countries like ours, where we get such big tumors, it is best to give sequential followed by radiation. So that is one point which I want to make.
Okay.
And the other thing is that there is also a meta-analysis on the toxicity of concurrent taxanes versus etoposide, published again around 10 years back, which says that taxanes is more toxic when we give it concurrent.
And Dr. Mujamil, any comments on that? Sequential versus concurrent?
I would go with the Dr. Akhil. Whatever he has said, I would concur.
Okay. So, Dr. Harpreet, anything concurrent versus sequential?
I would again prefer concurrent if the patient's performance status is good. And I can, the situation is such that the normal lung, I can save, I can have a significant amount of normal lung, which is not receiving much of radiation. And if I am able to achieve my, as per the contact, if I'm able to achieve my organs at risk doses, I would prefer CTRT over sequential.
So the data does favor, So synthesizing all what you have said, the data does favor utilization of concurrent CTRT. But as Dr. Sushma was also pointing out, it's not a real world situation that we face across. We do have these frail patients or these patients who are who we understand that they won't be able to tolerate a concurrent chemoradiation setting. So and obviously in
one more thing is that we published our data of the concurrent and sequential, and we found that the survival was similar, though the patient numbers were small, 50 patients, because most of the patients
prospective data, madam.
I mean, of our not a randomized data,
no, prospective,
but it was in South Asian Journal of Cancer, and we also wrote up the challenges. So most of the patient, 90% land up in metastatic. That time we didn't have PET. So we found that the survival of concurrent and sequential was the same. So why give toxicity? So from that point onwards, I almost never go in for concurrent.
Okay, right. So I will take it as words of wisdom, madam. I think it's a good thing that you have published your data also, and I hope it is a prospective one. So let's continue the case. This patient developed radiation pneumonitis and was started on steroids, and after tapering doses of steroids, it was stopped. Coming back to Dr. Akhil, so I understand that for an adenocarcinoma setting, you would go for PEM carbo as your chemo partner. And if at all you're faced with a setting where you're not able to use durvalumab, which is like 99% of at least my practice, what would you do? Would you give consolidation chemotherapy, or how would you do PEM-carbo in that particular setting?
See, I again concur with you that 99% of our patients will not be able to receive durvalumab. So that is the real world scenario, and we all are facing the same issue. The US practice, the NCCN, everyone favors to complete total 4 cycles of 3 weekly chemotherapy, if not more. If the patient is in a shape to receive further 2 cycles of treatment, I would be happy to give further 2 cycles of the treatment. But I again would agree that around 30 to 40% patient will not be able to receive those 2 cycles of consolidation, if at all. Yeah.
Fantastic. Dr. Sushma, the radiation dose that you use, any effect of increasing the dose?
So
do you think
we are in the type of tumor which you have shown, most often we are able to achieve 60 to 66 gray after induction chemotherapy, where about 30% downstaging is there. And in almost all the patients, the V2s, V20s and the mean lung doses are achieved. So that is never a problem. Only if the tumors are much more bigger, occupying 1/4 or half of one side of the thorax, then in those cases we cannot go more than 45 to 50 gray, where the spinal cord comes in between.
Fine. Now, how often do you see radiation pneumonitis as being a clinical issue in your practice, ma'am?
Yeah, we see it like not more than 5 to 10%.
5 to 10%.
Yeah.
Okay. Suppose if that patient happens to be an EGFR mutation positive one, do you think radiation recall pneumonitis is an issue when the patient progresses and starts in EGFR TKI? Do you see that?
I have never seen such case of a radiation recall. But
any of my panelists have
maybe I should be more vigilant as to whether they were EGFR mutated or not. But since the incidence is, because I am not giving concurrent, so that is why my incidence of radiation pneumonitis is very low.
Okay, right. Any of my panelists have this experience of EGFR TKIs causing? I mean, ultimately, these patients, majority times, will not be able to cure them, and they would be receiving subsequent treatments. And if they are EGFR positive, you'd be starting TKIs at some point of time. Do you think, have you experienced such scenarios?
I have not experienced it.
Okay, thank you, Dr. Muzammil. Akhil?
Most of the time, EGFR TKIs do not lead to so much of recall of pneumonitis. We have seen a lot of patients who progressed after completion of CTRT or RT alone, whatever. We have used EGFR TKIs in a lot of those patients. Most important thing to be pointed out here is the drugs like first generation TKIs, gefitinib and erlotinib, do not cause so much of pneumonitis, while the incidence of pneumonitis is somewhat higher with osimertinib. But yeah, but the use of osimertinib is still low in our patients. That may be one of the reason that we might not have experienced.
Very true, very true. So all the more reason to look forward to LAURA trial, I guess. Yeah. So coming back to the flavor of today's discussion, the Pacific study. Some important points are these patients should have received concurrent chemoradiation therapy and should have started durvalumab consolidation or gone into the randomization within 42 days post CTRT and should not have progressed. So these 3 points are, I think, are critical, and the primary co-primary endpoints being PFS and OS. So keeping this in mind, let's go forward. This is the real world study, and 169 of this Pacific real world study they have received sequential CTRT. So a significant percentage, let's say about 10 to 15%, have about 15% have received sequential CTRT. So I think we can take heart from the data that it is not only concurrent chemoradiation patients. So Dr. Muzammil, in your practice, if your patient is not able to take concurrent CTRT and is a candidate for durvalumab, do you give or do you not give, citing the trial data being only in concurrent chemoradiation?
Yes, yes, yes. If patient is affordable, I will give, even if he has received the sequential CTRT. In a
Okay.
real world practice, it has again benefited the patients.
Okay. And regarding the time period, the time lag of 42 days that the trial suggests, what is your take?
Yeah. Trial suggested from 14 to 42 days. So in between, if we can be able to give, it depends upon the finances. Actually, I have not given to any patient yet. Tried to give, but because of the financial issues.
Yeah, it is very difficult. I can clearly sympathize with you, and I have given in so many number of patients. I can show in all my fingers, and I will be left with most of my fingers still to be counted. So it is a very uncommon situation for all of us practicing in India. Dr. Rakil, your take on
So I would like to request to just
to
5
wind
minutes
up.
left. Yeah, sir.
I will
Sure.
just come to the final. Yeah, this is
Thank you.
probably the most important. I will come to this. Dr. Akil, so are you happy with this for this plots that are shown for OS and PFS? Do you think durvalumab benefits across all subgroups?
Yes, and the data is very strong. In fact, if we don't use durvalumab, the PFS is only 6 months, and the median crosses around 18 months in the updated data. So why we should give the benefit to every patient? The only place where we are having confusion is the EGFR positive one. Otherwise, definitely everyone. In only EGFR selected group, we might have some confusion, and we eagerly await the LAURA data as you discussed.
Okay, so Dr. Mujammil, what do you do for an EGFR positive stage 3B NSCLC, durvalumab or osimertinib? I mean EGFR TKI. Suppose if the patient is able to afford durvalumab,
Since the
data or not?
It is benefiting them. This is across the left side still. But better will be the if we have anti-EGFR treatment available for them, because you have Neo LAURA and this Neo ADAURA as well as LAURA trial data that is coming up. If we have access to osimertinib, yes, it will be good to give in those patients from stage 2 to stage 3 patients adjuvant, what you call to say osimertinib.
Okay, and across PDL1 also, irrespective of PDL1, do you give?
Since it's still not clear, it's not clear yet. Benefit is for those patients as well who have PDL1 expression.
Okay. Dr. Akhil, tomorrow your case, post CTRT, patient is PDL1 1%, EGFR positive, exon 19 deletion, post CTRT, can afford both durvalumab and osimertinib. What will you do?
Till now, there is no category 1 recommendation for osimertinib. So would like to offer durva only into the patient, but will be very careful about the progression in that patient, because the only worry is that if the patient progresses while on durvalumab, then I have to use TKI. Then after using durvalumab, giving osimertinib might lead to increased pneumonitis. That is my only worry.
Have you encountered such scenario?
Yes, we have already encountered.
I have encountered also. In 50% of my patients, it was EGFR positive, and both progressed within 7 and 8 months of durvalumab, or while on durvalumab. And one patient had brain progression, another patient had lung progression, and after starting osimertinib, developed such bad pneumonitis that she was continuously on oxygen for rest of her life. So it is not a easy situation at all. So I mean, at least I feel it is a little gray area. I think if you have any, I think everybody feels.
I think LAURA trial will give answer to this.
Yeah. Hopefully, yes. With that, I think we should wind up, and we have discussed all of them. The time of first assessment, Dr. Vincent has so eloquently put that plan ahead while the patient is about to come to the end of CTRT, plan for your next assessment and try to start as soon as possible. Best time is to start within 2 weeks. If most of our patients will not be able to do that, and 2 to 6 weeks is what most of us get. And even after it is after 6 weeks of treatment, there is still real world data to suggest that even late durvalumab does help. And patient had responded, and This is all what were discussed earlier. So the key point here is the curative intent of treatment. The curves clearly show that a clear plateauing, and probably a proportion of these patients are likely to get cured, and that proportion of patient is clearly improved with addition of durvalumab, the current standard of treatment. So the key takeaway from this discussion, I thank all my panelists for their wonderful insights. MDT approach is best and it gives the best outcomes for our patients. So the patient should get treated in a center where there is a MDT approach that can be taken, not in individual practices. Chemoradiation gives better outcomes than RT alone or CT alone. Durvalumab is the first and only approved immunotherapy. Consolidation chemotherapy doesn't improve outcome, it says, but we do encounter scenarios where we have to give consolidation chemotherapy. Durvalumab should be considered as standard of treatment in all the subgroups, though there is still a doubt that exists in the biomarker driven, especially EGFR and possibly ALK as well. And irrespective of PD-L1 status, I think we can still give this drug as per the data that is given. And we all agree that it is the new standard of care. With that, I conclude my panel discussion. Thank my panelists and thank the organizers for giving this opportunity.